Transoral laser microsurgery is a little different than transoral robotic. You can be trained as a transoral laser microsurgeon and then kind of switch into robotics. It's kind of hard to go the other direction. The best way I can describe it is patients know Mohs surgery. Mohs surgery, where the surgeon will go in, they'll take out the tumor, but then they'll start to map out beyond that to get to the edges. So in the transoral laser microsurgery technique, we are looking at here's where we see the tumor physically and visibly, but we acknowledge that my eyes and my hands can't three-dimensionally tell how deep the tumor is. And so in a transoral laser case, whether it be tongue, pharynx, what we call the supraglottic larynx above the vocal cords, or even the glottic larynx, the idea is you're going to divide through the tumor and take it out in quadrants. And so say somebody has a tumor on their epiglottis, which is the little flap that's above their voice box. I will intentionally divide through because I want to know how deep does it go, rather than guessing and taking more tissue than I need or taking less tissue than I need. And so in that transoral laser technique, you will divide through and you'll take out the tumor in quadrants, kind of like you do Mohs surgery, and then you keep on clearing the margins as you go. And in doing that, you do two things. You maximally remove the tumor, and you minimize damage to surrounding structures, and you minimize tissue coming out that doesn't need to come out. In a standard open resection, we literally just palpate the tumor and you start to cut around. You start to sort of go by palpation. And if you look at the historical literature on that, there are areas where you're close and there are areas that you're really far away. And so there are areas that you could have done better in both directions. And the transoral laser technique allows you, just like the analogy I gave previously, where you can operate inside the house but not take the walls down, it allows you to take out the tumor through an endoscopic approach, not disarticulate the muscles of swallowing, not change the skeletal framework, preserve those functions, but also do so and conserve as much tissue as possible so recovery is faster. So early return to speech, early return to swallowing, and a more complete return in both of those. The word standard of care can sometimes be almost weaponized. Like people say, well, this is the standard of care, this is how you do it. And in the late 90s, chemoradiation therapy was sort of, somebody wrote in a journal article, it should be considered standard of care. And all of a sudden, because somebody wrote that, everyone said, well, they said that. Standard of care, in my mind, and I think most people would support, is what are the accepted approaches to take something out? And so I think surgery for some tumors is considered standard of care. For example, the oral cavity. Chemoradiation therapy sometimes is considered the standard of care, and sometimes they both are. And within the realm of surgery, when you start shifting towards surgery as a standard of care, the real question is, which type of surgery fits the best within that standard of care? And so for the most part, you wouldn't advocate that transoral laser microsurgery is needed when somebody's got a large tumor where you're going to have to remove structural framework. But if you're thinking about somebody who's got a tumor by the voice box, historically that would have been an open surgical technique called the supraglottic laryngectomy, which has a long time speech and swallowing dysfunction recovery. And people did recover, but they didn't do as well. And nowadays, I think most people would tell you, if you have a tumor that is not visibly accessible, they should either get conservative chemoradiation therapy or they should try and get a transoral approach, because you're trying to save form and function. And so where that shift between open surgery and endoscopic surgery, whether it be transoral laser microsurgery or robotics, really is that access point and that functionality point. And so for me, I consider the endoscopic approach a standard of care when I'm trying to save function. And I feel like that is equivalent to what you can get with chemoradiation therapy. Whereas open surgery, we're already accepting that some function has to go because the tumor is dictating that. And then the advantages of doing it endoscopically are lost. I think it's important that when patients come to a facility, especially a quaternary care facility, they should have the option of seeing all of and hearing about all of the potential treatment options, because nowadays there are equivalent options. And I think we need to move away from paternalistic medicine where I tell you what to do, and we need to move more towards a shared decision making and a personalized medicine, realizing that it's not just the patient's tumor, but it also may be their comorbid conditions, what they value in their life, that then starts to allow us to figure out what therapy might fit best them. Because there's treatment of the disease, there's treatment of the patients, and when that Venn diagram overlaps completely, it's awesome. But when it doesn't, we have to start thinking about which therapies offer that person not only potential survival advantages, but also what's important to them for quality of life. And so if you don't have those options to offer the patient, then you're denying them those opportunities that they otherwise would have. And so I think every patient who has cancer should have the ability to understand what trial therapy is open. Is induction therapy available? Is lower dose radiation chemo or transoral surgery an option for what I do? And if you see somebody who doesn't do that as an option, you're probably not going to get offered it and then not know that it exists. There are very few people who are trained in doing transoral laser microsurgery. So when I was in training, for example, there's maybe 2 or 3 fellowships that trained it. Everyone else was moving on to robotics. And so there are very few people across the country who truly are trained in transoral laser microsurgery. And it's one thing to take off a small little vocal cord cancer with a laser. It's another thing to understand how to use a laser to do a more advanced tumor. And so you'll probably find a few islands across the country of people who were fellowship trained, like myself, who did 80 cases in fellowship all throughout the throat and can handle not only small tumors, but larger tumors and understand the access, what is going to happen, counsel the patients ahead of time, what to expect. And so there's some centers that may have a laser and you can turn it on, but do you have the skill set to counsel them ahead of time, to rehab them afterwards, and then to understand the best way to get them access and what needs to come out so you can give them the best possible outcome? And without that training and the iterative cases over the years that you need to do to keep that skill set up, then you really don't have a transoral laser microsurgeon. You have somebody who uses lasers.